Assalamualaikum and good morning. Welcome delegates to the National RA Symposium 2023 in Johor Bahru. It is an honor for me to present the next speaker. Many will know him from his numerous publications and recently being his group's technique on selective trunk blocks. He's a well-known Asian guru, if not the world. Besides being a professor from Chinese University, Hong Kong, he is also an avid angler. Our personal acquaintance of our fraternity since the early 2000s. It is my pleasure to invite the next speaker for our session, Professor Manoj Karmakar. Welcome.
Good morning, ladies and gentlemen. Firstly, I'd like to thank the organizers for inviting me to speak at this meeting. I can see a lot of enthusiastic people out here in the audience. I'm sure your quest for knowledge will be fulfilled by the time this conference ends. It's always a pleasure to come back to Malaysia, and as it's been mentioned, I have a very avid interest in angling, and I like many of the places in Malaysia that offer this sport to many of us. Now today my goal is to talk about some new techniques of thoracic blocks. Now a host of these techniques have been described in the literature. I will try and make sense of it all so that you can then decide whether these techniques are worth practicing, whether these techniques are worth delivering to your patients, and so on and so forth. I have no conflict of interest whatsoever relating to this presentation. Those of you who are interested in regional anesthesia, ultrasound guided, I welcome you to the ISSS TV, where you will find everything you need in one single portal. Now, ladies and gentlemen, the gold standard for thoracic analgesia and anesthesia has been thoracic epidurals and paravertebrals for over a century. But recently, these techniques have been challenged. But before you decide whether it's really worth considering some of these new techniques, which have advantages, which have applications in clinical practice, I'd like you to remember that paravertebral block was described first in 1905. This is over a century ago. There is a track record of literature, there's a track record of history, there's a track record of published work saying that this technique works. In fact, did you know paravertebral blocks were used before the advent of general anesthesia? This is how surgery used to be performed on patients by painstakingly injecting individual paravertebral nerves to produce anesthesia of different parts of the body. Epidurals were described also 100 years ago. So before you dispute these techniques and you throw them out of the window, I'd like you to keep this in mind. Now, my presentation is based on a review that we have published in Anesthesia and Analgesia. This is an open mind review article. So all that I'm going to be saying today is based on this, and it'll be referenced. All the facts will be referenced in this. So I welcome you to follow this article if you are more interested in the topic. Now, actually, when you look at the paraspinal thoracic blocks, it stemmed from the publication by Mauricio Ferrero in 2016 by description of the erector spinae plane block. There's a very simple block. You perform a sagittal scan, you identify the transverse process, and you deposit the local anesthetic deep to the erector spinae muscle on top of the transverse process. As you can see here in these two cases, he has illustrated that it produces ipsilateral ventral and dorsal anesthesia. This radiological spread of contrast up and down the spine, deep to the erector spinae muscle. And this is the second case. You can see that it affects both the ventral and the dorsal rami of the spinal nerve. Given its simplicity, and over the years, a host of publications have been published in relation to this technique. In fact, there's been so much popularity that it was selected as the block of the year in 2017 by the Journal of Cardiothoracic and Vascular Anesthesia. I may be very critical to say, as you will see as the evidence emerges, actually this technique does not affect the area over the sternum. So what are they talking about? The next technique that really emerged was the mid-transverse process to pleura block. Now, paravertebral blocks, those of you ladies and gentlemen who perform paravertebral blocks, can be technically challenging, but with experience and training, it becomes a very simple technique, has widespread applications, and has produced very minimal complications in trained hands, including a zero incidence of pleural puncture. Now, when these proponents of these alternative techniques want to sell you these blocks, they often say, paravertebral block is associated with a risk of pleural puncture. Yes, it is associated, but what is the risk? In trained hands, it is negligible to zero. Okay, the mid-transverse process is very simple. As you can see here, you perform a sagittal scan, you identify the transverse processes, you place the needle midway between the transverse process and the pleura. So therefore, you place the needle within the intertransverse connective tissue. Nothing could be more simpler, could it be, ladies and gentlemen? Because you're now just placing the needle behind the transverse process, in the connective tissue rather than into the thoracic cage. Cadaver studies by these authors demonstrated that an injection using these techniques produces paravertebral and intercostal spread of the contrast in these cadaver models. Therefore, they describe these techniques as paravertebral by proxy. What this means is that it produces paravertebral anesthesia and analgesia without having to enter the thorax. I think they were a little excited looking at these anatomic images, because clinically, does it produce the same efficacy as a paravertebral block? We will see that. The paravertebral lamina technique is an alternative technique that we inject next to the lamina. So instead of the transverse process, you place the needle on top of the lamina and you deposit your local anesthetic. The same terminology would be a retro-lamina block today in today's world. A multiple injection costotransverse block has also been described. This is also a variation of the mid-transverse process to pleura block. A subtransverse process intraligamentary plane block has also been described. Now, this is a mouthful of many words and acronyms, but ladies and gentlemen, they are all very similar to each other. Injection points are quite similar, and I will illustrate that to you. So if you look at the tabulated techniques, there are about 7 different techniques described in the literature. The retrolaminar and erector spinae plane block and the paravertebral lamina blocks are actually not injections into the intertransverse connective tissue complex. But in the interest of this discussion, we will consider all these techniques as paraspinal blocks because they are all performed within the paravertebral anatomy and they have a fairly similar mechanism of action. So if you see here in this anatomical picture, you can see that the ESP is performed just behind the transverse process. The mid-transverse process to pleura block is performed at the center of this anatomy between the transverse process, posterior surface of the transverse process and the pleura. The still block and the costotransverse foraminal block are also quite close to each other. The costotransverse foraminal block is where the posterior ramus emerges from the intervertebral foramina to enter the posterior anatomy. The base of the transverse process is often used as a surrogate landmark, and the needle is placed and the local anesthetic is injected. So how do these paraspinal blocks or the intertransverse tissue complex injection produce anesthesia or analgesia? Did you know there are fenestrations or gaps within the posterior wall of the paravertebral space, which is the superior costotransverse ligament. So the superior costotransverse ligament is not a watertight ligament. It is not impervious. There are fenestration. So any injections behind the superior costotransverse ligament, depending on the volume you inject, can get through the paravertebral space or intercostal space. There are alternative pathways, like to the costotransverse foramina, to the costotransverse, recently described costotransverse space, and even along the vasculature that traverse the superior costotransverse ligament. So an injection behind these intertransverse tissue complex can make its way into the paravertebral space. Now, given that there were a host of these techniques described today in the literature, the nomenclature of this has been standardized by the ESRA and the ISRA committee, and today it is all described as intertransverse process blocks. Now, the intertransverse process block is self-explanatory because you are injecting between the two transverse processes. You are injecting it into the connective tissue. As I mentioned, the ESP and retrolaminar blocks are injections behind the intertransverse ligament, and they are strictly not intertransverse injections. But for this discussion, we will describe them as thoracic paraspinal blocks. Because their sites of injections are very close to one another, and the proposed mechanism is by paravertebral spread. Now, there are some common attributes with these techniques. It's important to understand this, that it's all ultrasound guided. 2, they are often performed using a sagittal scan. They do not require direct needle access to the paravertebral space. And this is one of the points that the proponents of this technique say: we don't need to enter the paravertebral space, so it is safer than a paravertebral block. Yes, in theory it is safer, but is it as efficacious? I will try and prove that to you. The needle tip is positioned at a variable distance, so they are all different techniques, but they are all positioned at a different position at a variable distance behind the superior costotransverse ligament. And as you will see, that many of these techniques don't even require identification of the superior costotransverse ligament, and they use surrogate bony landmarks to perform these injections. So thereby, given this simplicity, they are described as technically simpler to perform. They are effective alternatives to they are described as effective alternatives to a paravertebral block. They've been touted to be potentially safer, and thereby, given their inherent technical simplicity and their theoretical safety, definitely they are attractive alternatives. And therefore, this has led to widespread enthusiasm for these thoracic paraspinal blocks. But do we know enough of these blocks? The strange thing is, despite thousands of publications on these techniques, and it's almost been 7 years since the early description of this technique, we don't have a mechanism of action. So it's still controversial. What is the exact mechanism? But a review that was conducted came to the conclusion that the most probable primary mechanism is a direct effect of the local anesthetic on the neural structures. So it has a neural mechanism. Which neural structures are involved is still debatable. It's also controversial, as we have proposed, that these techniques produce very high concentrations of local anesthetic in the plasma. So maybe there is an effect of the local anesthetic, systemic effect of the local anesthetic producing some of the analgesia that these techniques produce. Others have said it's not a rest-in-peace block. It is a very important block in our armamentarium. So, ladies and gentlemen, my aim of my talk is to draw attention to the retro-SCTL space. Many of you may not be familiar. This is a new anatomical concept in the horizon, and this, I believe, has an impact on how these blocks produce anesthesia or analgesia. And I propose that this may be the missing link in our understanding of the elusive mechanism of the thoracic paraspinal blocks. I will then show you how to identify the retro-SCTL space, an objective ultrasound technique by which you can identify this target and you can perform an injection. So when we look at the paraspinal blocks, Magnetic resonance imaging studies in patients have shown that when you perform a erector spinae plane block, it not only spreads within the paraspinal muscles, but it also spreads to the epidural space. It also spreads up and down the epidural space, as you can see here. Also laterally, it can spread to the intercostal spaces. So this may be how intercostal and ventral and dorsal rami of the spinal nerves are affected. If you can see here, the radiological spread to the intercostal, neural, and epidural foramina in these 6 patients are quite variable. You'd accept that in this wonderful spread in number 1, you'd get a very efficacious sensory block. But look at the one in number 4, 5, and 6, or even in 2 and 3, they are very variable. This is one of the limitations of many of these blocks. You can see that this is a sensory block on the ventral and dorsal aspects of the chest to pinprick and temperature. You can see that this is quite variable. So although that you have spread from the erector spinae plane to the neural foramina, intercostal space, and epidural spaces, the extent of sensory block is usually variable, as illustrated here. There are umpteen number of cadaver and radiological studies. To save you the grief of trying to review for you this, I have summarized them to say that the cumulative evidence in cadavers and radiological studies indicate that there is a physical spread from these paraspinal targets to the paravertebral space, to the intervertebral foramina. It also spreads to the epidural space. Thereby, it affects the thoracic somatic and sympathetic nerves, including the dorsal root ganglia, in both the paravertebral spaces and the intercostal spaces. So, to you it may appear, yes, this is where the somatic and sympathetic blocks are produced, and therefore, if you are too excited, you may say, this is paravertebral anesthesia or analgesia. But what people fail to understand is that although there is physical spread to these neural targets, this is variable, as I illustrated to you in the MRI study, and there are many more of these, and this is a cumulative evidence for me. There is spread, but it's only a small fraction of the total injectate. Just because you see a beautiful epidural spread does not mean it produces epidural anesthesia. So the question is, you mustn't take a pretty picture to produce a pretty block. So a pretty picture does not produce a pretty block. Think about it. The paravertebral spread that you see is unpredictable. It is volume and time dependent. So these techniques rely on the injection of volumes of 30 to 40 mils. So therefore, you have a limitation here. More importantly, the spread is confined to the posterior part of the thorax. So if you are aiming to produce ventral rami effects, if the most of the local anesthetic is confined to the posterior part of the chest, then there is a loss of effective volume of local anesthetic. The amount of local anesthetic that reaches the ventral part of the neural targets are actually quite a small amount. So there are some comparative anatomic studies, and I think it's important to highlight them. This study compared retrolaminar with paravertebral blocks. They showed that, yes, there is spread after retrolaminar to the epidural space, to the paravertebral space. But again, this is a repeating theme. You can see this is quite variable and is very limited compared to a paravertebral injection. Now, if you inject local anesthetic into the paravertebral space, you're depositing a large mass of local anesthetic. It is this drug mass that produces your anesthesia and analgesia, not the spread. Now, if you do an ESP or you do one of these paraspinal blocks, want of a better word, yes, there will be spread to these targets, but the mass of drug that reaches these targets are quite limited, they are quite variable. This is another study that compared retrolaminar with erector spinae plane block. They showed that the number of thoracic spinal nerves affected was greater with ESP than an retrolaminar block. And the spread was greater posteriorly than on the anterior part to the paravertebral space. Again, it is a recurring theme that you are seeing, that it is mostly confined to the posterior part. They also showed in this study, when you combine erector spinae with a retrolaminar block, there is a greater spread to the paravertebral space. Again, this may be related to the number of injections. This is a study by Dr. Adhikari and their group, one of the earliest studies, MRI studies, but in cadavers. To your left is the erector spinae plane injections, and to your right is the retrolaminar block. One of the flaws of this technique, of this study, is that the techniques were performed in the same cadaver. So as we know that if you perform an injection on one side of the spine, it may affect the injection on the other side of the spine. So the reliability of this data is quite limited. But nevertheless, you can see here that there is spread after a retrolaminar block or an ESP. You can see here in the thoracic segments from T1 to T8. You can see that it is variable whether you're looking at spread in the epidural space, neural foramina, or the intercostal spread. This is radiological spread, ladies and gentlemen. So the cumulative evidence for sensory block is that after an ESP or these paraspinal blocks, yes, it can affect the ventral and dorsal rami of the thoracic spinal nerves, and thereby you can get sensory anesthesia of the anterior or posterior part, but this is highly variable. It is inconsistent, and it's often confined to the posterior thorax. And there are also data from Japan that's painstakingly recorded many of these sensory blocks, and they showed that it does not indeed affect the parasternal area. So you may see many publications describing the use of paraspinal blocks for cardiac surgery. I urge you to be cautious in the interpretation of this data, because unless you review the entire data, it's very difficult to know whether it really works in those situations. This is a study right out of the press. You will see here that the spread of local anesthetic was studied after an ESP in healthy volunteers, so they also did sensory blocks. The conclusion, again, is the repeating theme, is that you get beautiful radiological pictures in the MRI spread to the epidural space, to the intervertebral foramina, to the intercostal space, but it underrepresents what you get when you actually do a sensory block. So now many of the proponents of these paraspinal blocks are now moving into the theme of era of trying to explain to you that you get analgesia. Yes, there is no sensory block. This may be differential nerve blockade. That means small concentrations of local anesthetic are reaching these neural targets, which don't produce sensory block, but it may be differential nerve blockade because of differential diameter fibers, A delta B C fibers. But actually, the concept that they're describing is totally incorrect. That's a discussion for another day. Okay, so the sensory block is also inconsistent, and bilateral sensory block have also been described. Now this is it's a rare phenomenon, and it can happen with anything. You have extensive bilateral epidural spread. Significant plasma concentrations of local anesthetics develop after these techniques. So really, in order to understand how these blocks produce analgesia or anesthesia, ladies and gentlemen, I presented to you some of the limitations of these techniques. You need to keep this in mind, that we are comparing them, or we are going to use them as opposed to paravertebral or epidural anesthesia or analgesia in your clinical practice. If you make a wrong choice, then you are making a wrong choice for your patient, and you're doing a disfavor to your patient. So really, to understand these techniques, you have to have a clear understanding of the relevant anatomy. Now, this is morning, so it's easy. All of your minds are fresh. And from now on, I want your undivided attention for the next 5 minutes, because if you understand the next 5 minutes, you can forget about what I said toward this lecture, okay? Now, it is all pictorial, so it's easy. Now you can see the paravertebral space is a wedge-shaped space behind the pleura, anterior to the transverse process. It communicates with the intercostal space, with the epidural space, and with the contiguous spaces above and below. It is the superior costotransverse ligament, which is the thick ligament in between the two transverse processes, that is the posterior boundary. And as I mentioned to you earlier, that this ligament is not impervious, is not watertight. So local anesthetic injected behind this can make its way into these various neural targets. When we do a paravertebral block, this is what happens. You place a needle into the retropleural space, you inject local anesthetic, you will see widening of the space, anterior displacement of the pleura, and increased echogenicity of the pleura, and you can see the ligament complex posteriorly. This anatomy has recently been refined or redefined by some excellent anatomical work from South Korea. I like to commend this research group from South Korea by Dr. Cho and them, who have actually, for the first time, used 3D micro-CT anatomy to define some of the anatomical structures in vivo. Now, I'm very critical sometimes to cadaver dissection, because sometimes cadaver dissection can follow your bias. You cut it up, you make it up. Do you understand what I mean? But this is in vivo. They cut out a block, they make micro-CT of these blocks, and then they render them in 3D like you do for your normal CT and MRI. The images that they produced were exceptional, high quality, high resolution, and they were able to not only define the osseous anatomy, but the ligamentous, neural, and connective tissue anatomy. So let me just simplify this for you. You can see here, this is the intertransverse anatomy, the transverse process, and we have two sections through B and C. So B, you can see here, is through the intertransverse space, which is where the target structures are when we do a paraspinal block. And you can see here, this is through the costotransverse articulation. You can see here, between the rib anteriorly and the transverse process posteriorly, you can see this section. What you see here, ladies and gentlemen, is truly remarkable. You can see here that we are not only able to see the vertebral body, intervertebral foramina, but the ligaments, the muscle, and the connective tissue. What you see here is the superior costotransverse ligament is the blue structure. You can see that the spinal nerve emerges from the intervertebral foramina with its dorsal root ganglion, and before it enters the chest, both the ventral and dorsal rami are actually behind the ligament. Do you notice that? Okay? This space has been described as the retro-SCTL space. The anterior ramus then enters the thorax through what is described as the medial slit in the superior costotransverse ligament, and the posterior ramus, which is the structure here, the dorsal ramus enters the retro-SCTL space posteriorly, and the ventral ramus goes like so. So there are two slits within the costotransverse ligament. You have a medial slit, which is here, and a lateral slit here. So any injection posteriorly not only goes to the paravertebral space through these fenestrations within the ligament, but also can go through the medial and lateral slits, as you can see here. So therefore, a few targets become evident. You have an intervertebral foramina here. This is described now as the retro-SCTL space. This yellow structure here is the ESP plane posteriorly. This is to show you in higher resolution that the spinal nerve emerges. This is the superior costotransverse ligament. It enters the anterior, the intercostal nerve, and then you have a lateral and medial slit in this anatomical structure. Now we are looking at the anatomy from within the thorax, from anteriorly. You can see here, this is the medial slit, this is the lateral slit. The intercostal nerve is entering the thorax. Obviously the pleura is not here, but it will be retropleural. It lies on the SCTL, and there are many rootlets of these intercostal nerves. So although to your left is the current concept that I described to you, the anatomy has actually been redefined. So much so that now we have a retro-SCTL space which is becoming very relevant because it is becoming an important crossroad for where local anesthetic, when deposited, can not only go medially, but can also go laterally and anteriorly to produce many of the effects that have been described in the literature. So the lateral slit would appear like so, lateral to the lateral costotransverse ligament, and this is the internal intercostal membrane. A closer look here, you can see the SCTL's, retro-SCTL space here. Look at the ventral and dorsal rami and the dorsal root ganglion. They are actually in the retro-SCTL space. They are in the medial aspect of the retro-SCTL space. So this explains why an injection behind the superior costotransverse ligament and outside the thorax can produce ventral and dorsal rami effects. Make sense to you? Yes. So I think this is the anatomical foundation that explains why this. Now, let's go to the ultrasound imaging. You can see here now, these techniques, as I mentioned to you earlier, is the intertransverse sagittal scan. Red is the mid-transverse process to pleura block. It's an injection into the intertransverse ligamentous complex, and the structure here is the superior costotransverse ligament here. These are the alternative techniques, ESP, still block, and costotransverse foraminal block technique. So you can now see how these go. Okay, in the next part, I'm going to quickly take you through how you can identify these, the retro-SCTL space, and then how you perform an injection, and then I will conclude this presentation. We use a curvilinear transducer. It is based on experience that we have accumulated in breast cancer patients, where we use paravertebral blocks as our sole anesthetic in conjunction with sedation. It is a sequential ultrasound technique, ladies and gentlemen, for consistency, repeatability, that you can do on Monday as well as on Sunday. Sorry, Sunday is a holiday in most parts of the world. Sometimes you work on Sundays too. If you want to be consistent, then you have to have a repeatable pattern. So the ultrasound imaging performed is over the ribs. You go below the ribs into the transverse process level, and then the inferior articular process level. As you can see here, the inferior articular process level, this is an intertransverse scan. The important part of the inferior articular process is that it is part of the facet joint, but the inferior articular process is also very closely related to the foramina. So if you can identify the inferior articular process, you're just close to the foramina, and I will highlight that to you. As you can see here, that the inferior articular process is very close to the anteriorly you have the foramina. So if in ultrasound image you can see the inferior articular process, the foramina is located where my green dot is now. Don't worry, it looks complicated, but I will make it simpler and simpler and simpler for you. Now this is the sequence of images that you see. You can see here, this is the image you acquire at the level of the ribs and transverse processes. You can see the posteriorly directed transverse processes here, and it articulates with the rib. It has a big shadow. So bone is impervious to ultrasound, so it always casts a shadow. If you go below the ribs, you have the transverse process. And now you can see the lung sliding sign, which is the pleura. And then you can go below the transverse process, you see the inferior articular process. So this is the true paravertebral space. This triangular space that we are seeing here is indeed the true paravertebral space. And as I mentioned, showed you before, we have performed the injection, paravertebral injection into the paravertebral space. In order to identify the retro-SCTL space, we perform a transverse scan, as we have reported in this publication. As you will see in this short video, that it is a transverse scan using a low-frequency transducer, as you see here. We do the sequential scan, as you see, through 1, 2, 3, aiming to identify the inferior articular process. This is the first window over the rib and transverse process with this large acoustic shadow of the rib and the transverse process. You then slide the transducer slightly caudad where the rib shadow disappears, and now you're left with the transverse process. Now you're able to see the pleural laterally, and the apex of the paravertebral space emerges just below the transverse process. The next scan is at the level of the inferior articular process. You can see the shadow of the rib and transverse process disappeared. we are now seeing the entire paravertebral space here. Okay? Now, this is a simple trick. The caudal pivot of the lateral, when you pivot the lateral edge of the transducer. Now, those of you who are not familiar with what a pivot is, if you imagine a transducer is placed like this, it's got a right end, to you this is right, and a left end, right? So if I keep the left end fixed and I move the right end, do you understand? Even Siri does not understand, she says. So you just keep one end fixed and just tilt the other end, okay? So in this scan, we are performing a scan whereby you keep the medial end steady, but you just tilt the lateral end so that it lines up with the angle of the intercostal space, and therefore it is parallel to the costotransverse ligament. And when you do so, you can see here at the lateral end, you can see the ligament first of all very clearly. This is the superior costotransverse ligament, and you see the space behind. So it brings out multiple spaces here. You have the paravertebral space. This light green is the retro-SCTL space, and then you have the ESP plane behind. You can see here anatomically again, you can see here very clearly the retro-SCTL space is seen as a hypoechoic intramuscular plane here. Now, we often don't look at MRI so closely, but if you home in on the MRI and you look at this area, you can see that this whole area is fat-filled here. In fact, if you imagine this is the ESP plane, when you inject local anesthetic, you can see how local anesthetic can enter these various neural targets. As I show you in a more highlighted image here, you can see this retro-SCTL space now, as I showed you, can be identified, and it can indeed be a new target, because as I mentioned to you, the evidence is that when you perform these paraspinal blocks, they are all retro-SCTL injections. You agree with that? You're injecting it behind the ligament. The further away you inject, the less of the drug reaches the epidural space, paravertebral space, and therefore you get variable anesthesia. So if you want to do these paraspinal blocks, a medial technique is desirable. Today there is limited data, we are working on this, but conceptually you will see that the more medial you inject, the more of the drug mass will enter the target sites and therefore produce more efficacious analgesia and anesthesia. This is what I think is my hypothesis. So this is how we perform this retro-SCTL injection, aiming for the medial aspect of the retro-SCTL space. So this is your retro-SCTL space here, this hypoechoic space behind the ligament at the level of the articular process. The needle is inserted from a lateral to medial direction in plane and placed at the retro-SCTL space. Now there is a sweet spot which I still don't know. If you inject your saline, you will see distension of this space, and I like you to keep watching here because you will see there's not only distension of this ESP retro-SCTL space, but also a lot of turbulence within the spinal canal spread to the intercostal and paravertebral space. So this is the first time we have demonstrated in real time and in vivo how one of these paraspinal injections will actually spread. It not only spreads to the intercostal paravertebral, but also to the epidural space, and thereby produce the effects that it does. So we have reported on this injection technique, and the concept is that the more medially you inject, the more drug mass you get. So, in conclusion, the anatomy for the thoracic paraspinal block are more complex than previously described. Dr. Cho's wonderful work from South Korea has redefined the anatomy, so much so that we have now begin to understand that the retro-SCTL space is an important crossroad for the spread of local anesthetic for these paraspinal blocks. Now, to understand this simple concept, I like you to imagine the retro-SCTL space like an exoric lake. Now, exoric lake is a mouthful. What an exoric lake is that you have closed lakes which don't communicate with any other water body, okay? It relies on rainwater to fill up and dry up. But exoric lakes are lakes that communicate with one another through under channels, over channels, etc., so much so that it doesn't matter on the weather, these lakes are always full. Imagine, this is a lake, a picture I took in Patagonia in Chile many years ago, where we went fishing, obviously. We went fly fishing for brown trout. And you'll see here that these are glacial lakes in the mountain, and they communicate with lakes at the lower level. So what do I mean by that? You can imagine posteriorly the retrolaminar and ESP plane communicate with the retro-SCTL space. And because they are outlet channels, the retro-SCTL space will communicate with the epidural space. Through the fenestration, they can communicate with the paravertebral space. Through the lateral and medial slits, they can also communicate with the intercostal space. So, conceptually, you can see how an ESP injection can reach the various targets. The ventral and dorsal rami of the thoracic spinal nerve are actually located outside the thorax initially, okay, and located within the medial aspect of the retro-SCTL space. So therefore, it's possible to produce anesthesia and analgesia of the thorax, performing an injection behind these ligaments. As I mentioned, all these paraspinal blocks are retro-SCTL injection, albeit they're all injected at a variable distance from the neuraxis. Our preliminary experience agrees with the proponents of these techniques that they are technically simpler. Even the retro-SCTL space injections are not difficult. But ESP, which is performed furthest from the neural targets, produce variable, unpredictable, time and volume dependent spread to the neuraxis. So, yes, ESP is a very sexy technique. It's very simple to perform. But does it produce the same efficacy as a paravertebral and an epidural? It's for research to demonstrate that, and most of the publications are in the form of case reports, case series. More importantly, the spread is only a small fraction of the total injectate, and it consistently affects the dorsal ramus, and the effects on the end ventral ramus are more variable and confined to the posterior thorax. This is just a randomized controlled trial to show you that in well-conducted randomized controlled trials, when the paravertebral was compared to ESP for breast surgery, they found that not only the pain in the PACU was higher in the ESP, but also the opioid equivalent consumption was significantly higher. So it is feasible to perform these injections. We've also demonstrated that injecting into the medial part is possible, and the direction of the injection may matter. And this is for future research to dictate and determine. So I think the need for future research is to focus on the retro-SCTL space. Now the question is, only time will tell if these paraspinal blocks can really supplant a paravertebral or an epidural, as I mentioned, have a history over a century. I know the answer. I hope I have given you some food for thought that you'll take away and consider very carefully the next time you want to perform a paraspinal block. I'm not saying don't do it. There are applications of it, but you must think very carefully. And I believe that the training of thoracic epidurals and paravertebrals should continue, because there are some schools that are saying we should throw them out of the window. Not in my school. Thank you, ladies and gentlemen.